Hello, this is Dan Kelly. This is the comprehensive case study of a 64-year-old African American male. He came in complaining of shortness of breath, had a past medical history of chronic kidney failure or chronic kidney disease, diabetes type 2. He reported a productive cough and fever with shortness of breath times 2 days. The patient was seen at an urgent care and referred to the emergency room. Surprisingly, the patient was asked to drive himself from the urgent care to the emergency center. When the patient first presented to the triage desk, the patient was gray, pale. His blood pressure was okay, but he was satting at 76%. So he was not doing very well. He was very tachypnic at about 40 to 50 times a minute, and his heart rate was in the 140s. This gentleman, again, had a family history of diabetes, had a history of diabetes type 2. He had an AV fistula. He had CKD. Mother and father both had CAD. Brother and sister had CAD and MI, and he was a non-smoker, non-drug user, and up to date with all of his vaccines. The only review of systems was he was positive for fatigue, fever, chills, shortness of breath, cough, myalgias, and the cough was productive. He did not have chest pain, denied palpitations, hemoptysis, leg edema, any skin lesions, orthopnea, enlarged lymph nodes, or history of spleenectomy, and no wheezing. His vital signs were temp of 101.9. His blood pressure was 100/60. Heart rate of 148 at the time. Respirations were 50. Sats 78% on room air. We did put him on a non-rebreather, which brought that up to the mid-80s. He eventually went on BiPAP, and the highest sat we could get on him at that point was 91%. Physical exam, a patient generally appeared ill. He was weak, skin was hot to the touch, mucous membranes were dry. He had no swollen lymph nodes that were palpable, no JVD. He was tachycardic with with a S1, S2 herd, no gallop, no rub. Lung sounds were coarse throughout and diminished on the left side. We did a chest x-ray, we did a CT scan with contrast to rule out PE, ABG, we did put him on BiPAP, we did CBC, CMP, lactic acid, BNP, as well as magnesium, calcium, blood cultures, ionized calcium blood cultures, sputum culture, cardiac enzymes. We did a echocardiogram, EKG, and respiratory cultures. The differential diagnosis that we came up for him was community-acquired pneumonia, pulmonary embolism, and congestive heart failure. So the reason that we thought of community-acquired pneumonia was the diminished on the left side breath sounds. He had fever, he had chills, he had a productive cough, myalgias, he was short of breath and low CO2. Pulmonary embolism as well. He was positive for shortness of breath, low oxygen saturations, although he did not have chest pain. And then for congestive heart failure, he was positive for shortness of breath, however, did deny orthopnea, and there was no visible extremity edema, and he did not have an S3 gallop. So some of the key points that we took away from this was, actually, let me go back. So this patient was eventually admitted and had a non-STEMI MI along with community-acquired pneumonia. So we gave him a broad-spectrum antibiotic. He got 2 grams of ceftriaxone in the emergency room along with 500 of azithromycin His cultures were pending, and the plan was to change his antibiotics to something that was specifically narrowed to what shows up on the culture or sensitivities. They gave him Lasix in the emergency room, which he did not respond to, and so stat dialysis was called after nephrology consult. Cardiology was consulted. His initial troponins were 17, and the second troponin after 6 hours, was 79. So he was eventually started on a heparin drip. We were trending his troponins. This gentleman did not have any signs on his EKG that he was having an MI. However, troponins did indicate that he was. So the takeaway points for me in this particular case was, first of all, the need for a thorough, comprehensive understanding of pneumonia, what to order, the antibiotics that we needed to use. Also, don't make assumptions about the troponin. The physician that treated the patient originally thought that the troponin could have been due to the fact that he was a kidney failure patient. It was only after the troponins came back that were extremely high and then trending up that they decided that he was a non-STEMI MI. And then third, I did some research on the complications of pneumonia, and did find that there were several cases of MI along with arrhythmias and CVA as a complication of pneumonia. So I think the total of patients that had an MI with their community-acquired pneumonia was 2.3%. Arrhythmias are more common. They are about 8%. And interestingly, long-term arrhythmia that does not go away after the pneumonia is resolved is 0.8%. Pulmonary embolism is 1.3%, and CVA is 1.1%. So it was very interesting. I didn't know that. So that's something I will take with me for probably the rest of my career. Any patient that has pneumonia, I will be definitely looking for those side effects. And so that is my patient. I followed him up until he was discharged. He went to a rehab facility, and from there I did not know what happened to him, but his prognosis was poor. The EF that we got back the EF that we got back, I think was 30 to 40%. They did a second one, and it had decreased further. So I believe the plan was that he was going to be going to downtown at some point to our Texas Medical Center for evaluation for a heart transplant. That is my case study. Thank you.